Hi, I'm Dr. Mila Brujic, and welcome to this episode of the American Academy of Optometry podcast series. I'm joined today with Dr. Kaleb Abbott. Dr. Abbott, share with us a little bit about your background.
Yeah, I'm an assistant professor of ophthalmology and optometrist at the University of Colorado School of Medicine, and I practice in our dry eye clinic and Center for Ocular Inflammation and mostly see advanced ocular surface disease.
I think that you are perfectly primed and positioned to be talking about the article that we're going to be discussing today. And it's more of an overview article, but it's the impact of glaucoma medications on the ocular surface and how ocular surface disease can influence glaucoma treatment. If you could, Kaleb, just do a little bit of a deep dive with me on really the essence of the article.
Yeah, so a brief synopsis. So the prevalence of glaucoma is increasing. We know that about 4% of the population aged 60 and older have glaucoma, and 10% of patients aged 80 and older. And the most common treatment for glaucoma is obviously topical IOP lowering medications. However, these IOP lowering medications have many known mechanisms which actually cause or worsen dry eye disease. And when patients are having worsening dry eye disease with their topical medications, it leads to poor adherence with these medications and can lead to uncontrolled glaucoma. So over half of glaucoma patients have diagnosed dry eye disease, and 20 to 30% of those patients, it's very severe. And then we know that it's not only the active ingredients that's in these IOP lowering medications, but also the preservatives themselves. So over 25% of patients using preserved IOP drops have corneal staining, as compared with only 9% of patients using non-preserved glaucoma drops. And then the prevalence of dry eye disease increases with the number of drops that you're using, and then the signs and symptoms themselves are more pronounced with preservatives such as benzyl alkonium chloride and things like that.
So, Kaleb, how important do you think it is for us clinically to start thinking about either alternative preservatives, or even now with the advent of newer generation formulations where they're preservative free when it comes to treating these patients?
Yeah, I think it's really important. So by far, the number one preservative that's used in glaucoma medications is benzyl alkonium chloride. And originally, that was the one that was used because it essentially dings up the corneal epithelial tissue and allows for better penetration of the drop through the cornea. However, we now know that this facilitation is not really necessary for the drop to be effective. So preservative-free drops have been shown to work just as well as preserved drops. So trying to switch over to preservative-free drops can really help these patients. And again, the more that we do that actually causes dry eye in these patients, the more likely they are to not be adherent to what we're prescribing, which can lead to uncontrolled intraocular pressure and then further vision loss.
So, Kaleb, what do you think, or what do you feel that the role is with respect to maybe going into some of the MIG surgery sooner, and or thinking about laser, like selective laser trabeculoplasty, sooner in these individuals because of the potential influence on the ocular surface?
Yeah, I'm a big fan of surgeries for glaucoma management, especially SLT in general. I think that's a great option for a lot of my patients. I've seen it work wonders in many of my glaucoma patients with ocular surface disease. And pretty much one thing that this review article discusses, that essentially glaucoma surgery is almost always better than glaucoma drops regarding ocular surface disease. So even surgeries that like trabeculectomies where you have a bleb. So even having something like that where it can cause an uneven ocular surface, which can lead to poor tear film distribution, still isn't as harmful for these patients as benzyl alkonium chloride or latanoprost or timolol or other active ingredients like that.
So, Kaleb, if there's a takeaway, if you can share with us maybe one or two kind of clinical pearls from the review of what our colleagues should be thinking about when they're prescribing glaucoma medications and or managing these individuals, what are those one or two things that you would advise from the overview, just based on a clinical strategy to help to make sure that the ocular surface essentially is preserved in these individuals?
Yeah, I think we need to know that these drops impair corneal wound healing. They're very pro-inflammatory. They affect meibomian gland structure and function. They damage goblet cells. They cause just low-grade chronic inflammation long term. And I mean, each of these drops, you can go one by one specifically with how each one of these drops in general causes dry eye disease. But I think the key takeaways is that essentially every single glaucoma drop out there worsens ocular surface disease or causes dry eye disease. In general, glaucoma surgery is much better than glaucoma drops for ocular surface disease. And the last thing that we want to do is cause dry eye disease or worsen dry eye disease to the point that patients aren't using the medications that we've prescribed for them. Because again, once you do that, you're at risk of the patient's glaucoma then progressing and it leading to vision loss and worse quality of life. So this problem really extends much further than just quote unquote dry eye. It actually affects glaucoma progression and the risk of further vision loss and just worse quality life in general. So I think we need to all do a better job choosing treatments that are better tolerated for our patients, be it SLT or MIGS or preservative-free glaucoma drops, just to improve their dry eye, but also to improve their glaucoma course as well. And we now have options that are preservative-free. So we have Xioptan, we have Cosop preservative-free, we have Timoptic, which is a preservative-free timolol. And then as of recently, we now have Iuza, which is a preservative-free latanoprost. Then there's even a few other glaucoma drops that use less harsh preservatives that are probably better too, like Travatan Z using Sofzia and Alpha-Gan P, which uses Purite.
Yeah, Kaleb, one other question too. I know that you probably get some patients. I know that you're seeing mostly ocular surface disease patients. You're probably getting some people from the glaucoma department who have concurrent ocular surface disease as well. Are you really putting together strategies with those glaucoma physicians to make sure that you're optimizing things and not changing the path of glaucoma, but making sure you're optimizing that while you start treatment in these patients as well?
Yeah, I co-manage a lot of these patients with our glaucoma department here, and I'm constantly sending messages to them, saying, could we consider, maybe eliminating this drop and by doing SLT, or could we switch to the preservative-free option of this drop? And I find that that's really helpful too. But I mean, another, I guess, takeaway that I've noticed, not necessarily from this article, but my own clinical experience, is that when you have these patients that have used these BAK preserved drops for 5, 10, 15, 20 years, a lot of times they have this just persistent and unresolving corneal epitheliopathy. And I'll look to see how many of those drops that they've been on that have BAK in them, because we know that BAK can actually damage trigeminal nerve endings. So I start to suspect a lot more often now a neurotrophic component to their ocular surface disease, and I'm much quicker to reach for an anesthesiometer to check corneal sensation with those patients than with some of my other ocular surface disease patients.
Kaleb, this has been outstanding. I think what you've armed us with clinically is not only the contemporary body of information surrounding itself around current glaucoma treatments and also the sensitivities that we should have around preservatives, but also to those strategies to put in place to make sure that those patients that do require glaucoma care, make sure that we're preserving the ocular surface and ultimately functioning as best as possible. Kaleb, thank you so much for your time. Truly appreciate you being on the episode today.
Thank you.
And thank you all for joining us for this episode of the American Academy of Optometry podcast series.